Hello, everyone. This is Eric Glazer, and welcome back to Bright Spots in Healthcare, produced by Bright Spots Ventures. We are dedicated to accelerating innovation through content, communities, and forging meaningful connections. And our mission is quite simple. It's to spotlight what's working in our industry, and how to scale it. We bring together leaders from health plans, hospitals, and other healthcare innovators across the land to share proven strategies and tactics that drive meaningful impact. And through our podcast that are part in our executive councils, our private events, and our go-to-market strategy work, we try to surface and amplify the bright spots in healthcare, proven innovations others can learn from and replicate. And at our core, we exist to foster those trusted relationships that fuel real progress. We believe that the best way to improve healthcare is to find what's working, find a bright spot, and clone it. If you have not subscribed to the podcast, you're missing out on incredible insights and bright spots from industry leaders across the country and the world. So I encourage you to go to your podcast app, your favorite one, and type in Bright Spots in Healthcare and subscribe. Today's topic is doubling down on Medicaid innovation in a post-OBB world. Our guest today, we're not going to do bios. We never have time for those. We want to use that time for discussion. We'll post the bios in the show notes. And if you're watching live on Zoom, we will get those. We'll post a link for the bios. But our guests today are Laurie Stradley, CEO of Impact Health. Our second Laurie, which I'm sure we're going to confuse each other today, just in order here that we're introducing them. Laurie Andrade. She is the Executive Vice President of the Health Equity Alliance of Long Island, or HEALI. And we have Dr. Joneigh Khaldun. She is the President and CEO of the Public Health Accreditation Board. And we have Evan Jones, the Chief Strategy Officer at Vircho. Incidentally, Vircho is our partner and our new sponsor of today's episode. They are an organization that works with health plans and government and community care hubs to connect healthcare with social needs that impact health, so they're a perfect kind of addition to today's show. They provide tools that make it much easier to deliver community-based services and improve outcomes for the people we all serve. And you can learn more about them at vircho.com, virco.com, and I'll tell you a little bit more about them later on in today's episode. Okay. You have a Q&A module, as all of you attending live know, and you can help me co-moderate the session by bringing in questions. I'll do my best to integrate them into the flow of today's discussion. We are pretty jam-packed. And when you think about innovation in Medicaid, I know sometimes we often think about those big policy changes, the new waivers and the new funding. But sometimes, getting on with the theme of bright spots, the spark comes from simply looking at the data differently and acting on it. And so one of the bright spots I identified tied to today is out of Camden, New Jersey. Dr. Jeffrey Brenner and the Camden Coalition noticed that a small number of patients with multiple chronic conditions, and you could guess unstable housing and frequent ER visits, they were driving a disproportionate share of costs. So instead of just waiting for that policy fix, they tried something a little bit different. They built interdisciplinary teams of clinicians and community health workers and social workers. And then they addressed the medical and social needs together, and they built trust with those communities. And the early results actually showed significant drops in hospital use and spending. And then the later studies revealed, it wasn't a silver bullet, but readmissions didn't fall off as much as they thought, but it did improve greatly the follow-up care and increased outpatient visits, and it strengthened those connections to the community resources that we're all trying to do. So those were bright spots that were worth learning from. And that's exactly what Bright Spots Ventures, why we exist, why I founded this organization, why we've been doing this show since 2014. We believe that the progress comes from what's working, even in part, and then figuring out how to replicate it. So that's what today's all about. Medicaid is under a ton of pressure. This one big, beautiful bill environment. And inside the challenges, we know there are bright spots. And our guests today are going to highlight some of these practical solutions being tested by Medicaid innovators, CBOs, public health leaders. So as you're listening today, grab a pen and paper. As you're listening to Laurie, Evan, and Dr. Khaldun, I encourage you to think about what is working. Think like Brenner did in Camden, and spot those ideas that are worth scaling, those seeds of innovation. And that's going to help us make healthcare better, especially in your markets. Take those bright spots and inspire new thinking. So we're going to start today at the ground level and talk about CBOs and who are on the front line. And I'm going to bring in Laurie Stradley, CEO of Impact Health down in North Carolina. Laurie, from your perspective, what's the very first step, whether you're a public official, health plan, whoever, but what's the first step to help CBOs becoming stronger, more sustainable Medicaid providers?
It's a perfect question for Bright Spots because that's where you start. There are incredible community organizations all over the country that have been doing this kind of work in food, housing, transportation for years, if not generations. And they're already doing the work really well. The transition to connecting with Medicaid means that they need new supports and skill set. It's anytime you change a business model, whether it's nonprofit or for-profit, you need to build capacity, build skill, build understanding of the new sectors that you're going to work with. So the first step is always going to be find the people who are already doing the service delivery well, and then lean into what we as a social care hub do well. And that's being the bridge, the connection between community care, which again has been operating forever, and clinical care, which is, goes back as far as it possibly could too. And how do we build that bridge between them? And so if you find excellence on both sides in the clinical space and in the community-based space, and work with a social care hub like us in the middle, which again is a national movement. They're all over the country, these groups that are trying to build these bridges and do good work to help bring it together and connect those dots. And so we have, examples here. I'm based in Asheville, North Carolina, and that might ring a bell for you because we're also fresh off a devastating natural disaster from last year. And for the first time in natural disasters at the state level, Medicaid was a part of the recovery directly. So not just signing waivers and doing all that, but actually delivering services. And it was this community care hub model that allowed that to happen so fast. And I'd love to shine a light on one of the agencies that we work with. Their nickname is ABCCM, but they're serving all of Western North Carolina, the Asheville Buncombe Christian Community Ministry. And they provide services like housing, transportation, clothing, food, even some medical care intervention in a free clinic and dental. But they had never worked directly with a clinical setting and a clinical payer. So they're one of the best in our region when it comes to meeting the needs of their community, being a trusted partner in all of this work. But again, making that transition to support a clinical intervention, which is truly what we're talking about here. It may be food, it may be housing, but it's part of a whole clinical intervention that's meant to support individuals. And so through our partnership, they were able to continue doing the great work they do, but now with a new partner and with a new influx of funding. And so over the last 3 years, they've expanded their staff by about 20%, and they've increased the number of food boxes and housing transformations that they've been able to provide while continuing to do great work. And at the same time, at Impact Health, we're providing the training and technical assistance that allows them to stay focused on what they already do well without disrupting that model too much, because it is quite a shift to go from writing a grant report about how and who you've supported to negotiating HIPAA protections within your data and privacy. And that's just a whole other world. And so if we can help make that part simpler and more effective, they get to keep doing what they do so brilliantly, which is to take care of our community. And we get to keep that happening and draw new funds into the region and support more people with more efficiency. And that's also the name of the game is get that support where it will have the greatest impact. As a community care hub that bridges these two worlds, we're not trying to solve hunger or to solve the housing disruption in all of our communities, but we're trying to be a part of that solution. And to the degree that we can support our community-based agencies in having an impact on all of these different ways to move the needle on hunger and housing, we can do it with a higher degree of efficiency, effectiveness, and data-driven solutions really than we've ever been able to do before.
Yeah, I want to get much more into that, especially the data-driven solutions. But I want to kind of summarize what I just heard, and feel free to jump in if I didn't get it right. But in the world of management or entrepreneurship, there's this saying, "Right people in the right seats." And when you're building sort of a network, especially in this world where we're kind of really over the last 15, 20 years have accelerated this conversion of these community-based organizations that really weren't seen as a healthcare asset. And now we're converting them into sort of like an extension of care teams. So we need to make sure they're doing what they're really good at, which is trust with the community and allow right people, right seats, and allow us to support them in being able to have the capabilities that make them sort of an official provider and all the logistics that we've put on them in our industry. And so what I'm hearing you say, Laurie, is by providing some of that support and letting them do what they do best, they increase their staff, and thus they've increased their reach and impact in the community. So it does have a nice flywheel effect on the impact it can make on community if you're able to provide some resources and expertise so they don't have to do things that they never signed up to be good at.
Yeah, Eric, that's exactly right. And I think it also shines another similarity between the clinical space and the community-based health space, which is that our docs, our nurses, they also don't want to be bogged down by billing and coding. And so in the clinical world, we have experts that do all of that work to help keep our docs and our medical providers doing the work that they signed up for. They want to care for people. They want to help them achieve their best possible health outcomes. And they can get really bogged down in the red tape as well. So learning from this means that as we bring clinical and social care together, we don't want to repeat the same problems that have plagued clinical care and kept them from providing the best possible care either. And so when we bring these two things together, that's a shared concern, is how can we make it so that folks are operating at the top of their expertise and doing that with the trust and reliance on organizations that can help make it easier for them, so they know that they may not be the ones that are eyeballs deep in compliance, but someone is who has a trusted background and can let them stay close to their people.
Right. And so I want to bring in now, so that was our North Carolina Laurie for everyone listening, especially if you're not watching. And so now we're going to bring in our New York Laurie, Laurie Andrade, and Andrade. I think I got that right? I know we practiced that. So let's talk, Laurie. You've got a network of CBOs on Long Island, and you need to connect patients to healthcare services, to social services. We need to make sure that their journey is as seamless as it possibly can, but they're going from, barbershop to food pantry to church throughout the community. There's no way those different businesses, those different not-for-profit businesses could truly know what's going on when they hit each stop, the member hits, or the consumer or the community member hits each stop. So how are you helping your CBOs work together to ensure that, the best possible journey happens and the patient could go from healthcare to social services in a seamless way?
Yeah, I mean, I think, we're a network of about 100 healthcare and CBO providers, and all of them are putting people at the center of care individually as a CBO or a provider, right? That's what we do. We are person-centric. We are about creating the best care for that individual and that family. However, we're kind of doing it in siloed systems, right? Because you have the healthcare system and the CBO system. The CBO system might not completely speak to each other. The healthcare system might not completely speak to each other, and they're certainly not speaking to each other. Is really what we're talking about. So, Laurie and myself, HEALI has a social care network, which is, again, the similar type of coordinated network that Laurie was talking about. We're really looking to create a system that bridges both. So, an individual on Long Island, we have nearly 3 million people, 600,000 Medicaid members. They don't have to go from organization to organization or healthcare provider or social care provider, retelling their story, re-traumatizing themselves again and again so that they could get access to care. We want them to be able to tell their story once, right? And the providers, there's a system of care there that the providers are able to then share that information and ensure that that person's care is being coordinated. And so that's really what HEALI was born to do, was created to do, is to really be that system of care, build out that cross healthcare, social care system to coordinate them between them. And so we're, really when you think about those two things, first is the important part of sharing data. We have to be able to have that person tell that story once and that data is captured and it's shared. So we need a technology system to do that, right? We need a system that everybody is onboarded into, trained on, knows how to do, and that is running smoothly. And so that's the first piece that we, when HEALI started, was we chose a referral technology so that could happen. And we're using Unitas as that referral technology. The second piece, though, I often say data does not provide services to people. Technology is not going to provide services to people. It's humans that provide services to humans. So we need to make sure we have a workforce that, again, is helping act as that bridge between social care, making sure that's running smoothly, and healthcare, making sure that's running smoothly. And really, that's a community health worker as the center of care, that coordination between the two. And so on Long Island, we've been really focused on building out our capacity to be able to collect data, share referrals, close referrals, get people connected to care, and then also be able to have a workforce that's going to ensure that coordination occurs as well, and is a trusted resource to people. So it's both being able to have a system of care that has data technology informed and has at the core, but also has a workforce that's making sure that coordination happens.
Data and technology will not provide the service to members. I like that. People will. So we got to combine people like CHWs with technology, and we got to figure out how to get these more nascent healthcare organizations or CBOs that are what I call that we're pushing them into healthcare, and we got to provide them with the data and the technology to do that. So I'm going to bring in Evan Jones, who's the Chief Strategy Officer at Vircho, and building, Evan, on what Laurie and Laurie just shared. How do these operational challenges influence how MCOs and other Medicaid programs engage with CBOs? And maybe provide an example of how a CBO solve for this, like the compliance issues and the billing hurdles and everything they need to do to actually have more scale and be able to make more of an impact for all of us.
Yeah, thanks, Eric. It's great to be here and a lot of great insights from Laurie and Laurie who are on the ground. So before I answer the question, maybe just a brief background on Vircho for context. So Vircho is an end-to-end operating system for social care networks. So a social care hub in an 1115 waiver state like North Carolina or New York, or an in lieu of services program, but also an increasing number of industry-leading MCOs who sponsor their own programs. They can use Vircho to manage those networks efficiently, and they can operate at scale. So I think to put a point on something, both of the Lauries and you said, if we zoom out, all of the CBO partners we work with, none of them set out to become traditional healthcare providers. And so we need to be really mindful about the burdens that we're going to place on them to enter into these programs. And there's going to be a tension between a mission-driven CBO and an MCO or a social care hub that is going to require a level of standardization, scale, and reliability across their network that an individual CBO doesn't need to worry about. And I think one thing, and Laurie Andrade mentioned this, we need to be able to bring data integrations and also actionable analytical tools to smooth out that tension. And so I think the shift from providing charitable services to being a credentialed, billable provider of social care is pretty significant. And so whether it's a Medicaid program or just an MCO-sponsored program, the CBO is going to have to take on a bunch of new tasks to participate and be compensated. So things like background checks for all of your team members who are going to be volunteers, many of them, running against OIG inclusion lists federally, tracking performance across delivery measures. But I think the biggest challenge is submitting accurate, timely billing, which is not something that in the charitable service delivery space a CBO is going to have to do. And that's a specific challenge that we tackled in North Carolina with regards to timely billing. So there were a number in Laurie's statewide program, focus groups and studies that came back to say CBOs found that the biggest challenge was timely payment. And now that they were receiving these reimbursements and this was a cash flow for them, they were then reliant on it. And so they felt like health plans in the state were not paying them fast enough. And we wound up digging into many hundreds of thousands of data points at the invoice level. And we found that it's actually a very different story. So even though the health plans and the networks in the space were being blamed for the delay in receiving timely compensation, what it actually was that CBOs had wide variability in how quickly they were invoicing for their services and how accurately they were invoicing. So there were many invoices that could be rejected at the payer level 10 times before they were accepted. This is just not something, to Laurie Stradley's point, that they know how to do and that there are experts in the healthcare field that focus on this. But now we're pushing that burden down to a local community organization. So I think how we tackled that is through some first surfacing the data to a point Laurie Andrade made of just having the data available and not siloing it. So when we found that CBOs had wide variability in time to invoice, some were day of service, but others up to 45 days post the service was when they were actually submitting the invoice for approval. Simply surfacing that back to CBOs wound up, opening some eyes and making sure that they could understand and address their own internal workflow issues. And on the second issue of inaccurate or incomplete invoicing, we actually worked with, some boots on the ground to understand the specific issues around invoicing, why they were being rejected both at the payer level and at the network level, and developing some technologies to solve that where we could pre-process invoices and all the supporting documentation so that we can assess their accuracy. And this was really a pain point for the networks and MCO staff because they were having to retain and build big teams to review increasingly large numbers of invoices daily. And so allowing them to focus only on the small subset of invoices that were very complex allowed that to improve for the specific CBOs. And then I think the last point I'd make is that, hearing from both of the Lauries, very different states, very different programs, and we've seen as well in conversations with many other states, both at the MCO and the social care hub lead, we might all think that our problems are very challenging and unique, but there is quite a lot of commonality, even though the details might be different, specific program to program and state to state.
Good stuff. Good stuff. And you're working at, and just so everyone knows, Vircho is working with a bunch of these community care hubs, these social networks, and ensuring that all this flow happens. One, that each individual CBO has the tools they need to be able to support the work they're doing for the community. And two, they're able to communicate with each other so that, similar to how a primary care doctor may be communicating through an EMR with a specialist, that these community care organizations know that when an individual person goes from one spot to the next, that they're aware of their journey, correct? It's like,
yeah, absolutely. We because we can cross borders, so to speak, and across data silos, any specific MCO, they're not going to know if a member is enrolled in a different plan. They're going to know nothing about them when they show up at the door, re-enroll in a plan. And because we sit across multiple closed-loop referral systems, to Laurie's point, we have a full picture view of what's going on in the community and in the state, which I think is just crucial.
all right, I'm gonna shift a little bit because I want to go big picture now into just the public health departments that everyone has to work with as well. And for that, I'm going to bring in Dr. Joneigh Khaldun. She's the president and CEO of the Public Health Accreditation Board. And so, Dr. Khaldun, how can public health departments support CBOs and advance social care efforts?
Yeah, first of all, thank you for having me on. I've really appreciated the comments from my co-panelists. And, I really think it is...
Can I do one thing too? And I'm sorry, I should have teed you up for this. I think folks should understand that you have this unique background of being a practicing doctor, running the accreditation board, and also being a former leader at a health plan. So maybe a little bit of yourself too, so people know where all this information is going to, the context.
Yes, thank you, Eric. So absolutely. So So first of all, just really, and I see a comment here about a WIC program, which I'll talk about. But it's really important that health departments are really at the forefront of a lot of these conversations when it comes to advancing the health of the most underserved and addressing social needs. To Eric's point, I do come at this from having seen health and healthcare from multiple angles. So yes, I'm a practicing urban ER doc. I've led local and state health departments, high-level state Medicaid strategy, social determinants of health work at a Fortune 10 company and health plan, and now have the honor of serving as the president and CEO of the Public Health Accreditation Board, which we call, and I will call ongoing on this podcast, PHAB. We have a fabulous team, by the way. And so PHAB is the sole accrediting body for governmental public health in the United States. For my healthcare folks, I like to say like PHAB is the JCO, if you will, for public health. And so we do accredit over 450 health departments. Over 40 states are actually accredited, as well as many local, state, territorial, tribal health departments. So why is that important? So let me pause for a moment. Why is that really important? I think it's really important that people understand what a health department actually does. Everyone experienced COVID, but oftentimes people don't actually know what a health department does besides like telling you need to get a vaccine. And so your health department is really the one who's investigating all kinds of reportable diseases and outbreaks. They're identifying the source, they're preventing further spread. They're the ones who are actually inspecting your restaurants and pools and making sure they're safe for you to engage with. They're running programs that provide important food and nutrition services, as was noted in the chat about the WIC program. Your health department is the one who's leading important evidence-based programs like your home visiting programs often, or your evidence-based interventions around lead screening and preventing exposure to lead for children. They're running important chronic disease programs, substance use prevention programs. Many of them are actually running direct clinical services. So that can mean immunizations, of course, but STI testing and treatment. Some health departments actually have FQHCs or primary care services embedded within them. And of course, your health department is also the ones that are creating and advancing policies in their jurisdiction that really keep people healthy, like access to safe water, access to housing. So as you can tell by the things that I'm kind of sharing, you need, like no one wants to live in a community that does not have those things, first of all. And you really want to live in a community where those things are not just happening, but they're happening at a certain high quality standard, and they're doing them well. They have capacity to do them well. And that's what my organization PHAB really assures across the United States. And whether it's a state or local health department, most people across the country are actually covered by an accredited health department. So I do think, again, given governmental public health's role, we really need to be at the table, an important player at the table. Again, I'm thinking about some of my time at the Detroit Health Department, where we actually were setting up technology and helping to coordinate different services across CBOs and with our Medicaid plans in the city of Detroit, as an example. But really addressing those social needs with the most vulnerable populations is the bread and butter of what a health department does, and really needs to be, I would say, at the forefront of these conversations around social care and clinical care and coordinating those services.
Great stuff. I have a follow-up for you I want to get into around closing gaps in care. But just real quick, a quick little PSA, folks. We try to, based upon your feedback, and incidentally, we're going to ask for your feedback in about 15 minutes through email. We'll put it in the chat. Survey takes 2 or 3 minutes to complete. So we ask you the favor of just providing some insights into the topics we should cover, but how we make these sessions better for you. One of the big things we learned last year was, hey, we come to a lot of your events, but we always have to register and put the same information in. If you want, we're going to register you for our next 2 events to start off October. We have one on STAR savings and satisfaction. We have another one on October 9th on GLP-1 integrations around plan design, member engagement, outcomes, and everything to do with what we're dealing with the obesity and GLP-1 situation in healthcare. Would love to register you for any of those. Just let us know and we'll do that for you. So Dr. Khaldun, I want to talk about how can public health organizations close gaps in care in partnership with social care networks, CBOs, health plans, et cetera?
Yeah, I'll pick up on what I said previously. I think again, health departments by nature focus on services and supports for the most vulnerable, and importantly, which is different than clinical care. Again, I'm a practicing ER doc. Your health department is really only or primarily focusing on those upstream kind of interventions, prevention of disease and illness before it actually happens. And so, in many communities, especially your local health department, they're leading a lot of those local level efforts. And so, let me give an example. When I led the Detroit Health Department, they've since expanded this program under great leadership of their health commissioner, Denise Fair. But the health department actually launched a program. And now this is pre-COVID, but it resonates now as well. But launched a program focusing on zip codes in the city of Detroit that had the highest levels of children who had elevated blood lead levels. And so we have, and health departments do have all kinds of community level data. Lead was identified as a challenge. Lead, is a challenge not just, for example, in the city of Flint, across a lot of, places where there's old peeling paint across the entire United States. So we wanted to do something. We looked at our data. We looked at those zip codes, and we literally, to the earlier point about the importance of the care team, we engaged community health workers. We really built out a program where those CHWs literally knocked on every single door, literally had a map and knocked on every door, like a door walking plan, identified needs in those homes, actually provided on-site, in the home, lead testing to people who needed it, pregnant women and children under the age of 5. We also, importantly, provided screening and referrals to important social programs, whether that was a program the health department ran. We literally, created a survey. If someone needed a job, if they had challenges with transportation, whatever that was, we were actually in those homes, a trusted member of the community, and were able to actually connect people to the services that they needed. And so, what's the point of that example, and what does that really exemplify? I think there's a few things. One, health departments have access to so much important community level data, whether it's your local or often it's kind of centered at the state level, but they have so much data. And many health departments, especially if you are one of the over 450 who are accredited, you have the capability and often an epidemiologist who will look at that data and look for trends and signals to help you really identify needs and direct your resources accordingly. And I would say that can be a very important resource for a community-based organization. A health plan, similarly, could share your population level data that you have for your members with the health department, right? Leverage some of those data resources that the health department has so that collectively you can actually have a deeper, more nuanced understanding of member needs and how they're accessing health and healthcare services in that particular community. And so a few other things I'd say, just briefly, health departments are often on the ground, to my example I made, working with those who generally have less access to care. So your health department, as I talked about my example, right, your health department actually needs to know who you are as a community-based organization and what you do, and they can actually make referrals. So you really need to make those connections. And then vice versa, you also need to know what your health department is doing. A lot of folks, unfortunately, don't know what health department does or the programs that they have. So as you are engaging with your own community members, you need to make sure that you know about the health department services. And then finally, I'll say, from a health plan perspective, often, Medicaid plans and health departments have shared priorities, particularly I'm talking about HEDIS measures. So as a health plan, for example, you could identify as a priority, you want to improve childhood vaccination rates. Obviously, that's a priority of the health department. You could actually work with that health department in improving that measure for your plan, which obviously there's great incentives to do so. So I think there's a lot of opportunity to identify shared priorities and then collaborate in an effective way.
Stuff. I want to shift a little bit now to CBO networks. Are back there again, because what I like to do for everyone now that you've got sort of the lay of the land and what we're trying to do with and how you guys could think about innovations, I want to start talking about a blueprint on how to build a strong social care, healthcare kind of strategy. And so we're going to ask everyone to kind of contribute to that. I'm going to start with Laurie, Andrade, and in New York. And Laurie, how does HEALI Health Equity Alliance of Long Island, for those of you following along, how do you ensure all the CBOs in your network are rowing in the right direction? Because I'm guessing it's get a little bit of a tug of war. And just how do you coordinate and sustain such a large network?
Sure. I do want to kind of piggyback on what Joneigh was saying as well, because in an urban environment, when there's one Department of Health, it's a really different than in a suburban environment. We have 900 layers of government on Long Island, 2 counties, 12 towns, dozens of villages, 124 school districts. So it's yet another siloed system of care with healthcare and the CBO social care. We have nobody from what we always say, the Queen's Border to Montauk, kind of driving care and coordination on Long Island, other than HEALI. We're the ones doing that work, because otherwise CBOs not only have to contract with managed care organizations, health systems, but they also have multiple contracts with all of the layers of government. So urban is one thing, suburban, and I'm not rural, but I'm sure Laurie could speak to more of the rural area. It's very different, the way in which systems coordinate, and without a social care hub or a social care network, it just isn't going to happen on Long Island, because we're the only ones that have our eye on the entire region and are worried about the coordination of care for the entire region. So that being said, how do we coordinate that? It's really bringing people together, and it's really ensuring that whatever system of care, if you look at the CBOs, the healthcare providers, our local government partners, we're ensuring that everybody, they're all subject matter experts, and we're making sure we're rising all of those subject matter experts to the top so that they can contribute to the way in which care is provided. And really, so HEALI really acts as either that umbrella or that administrative backbone that ensures that all of that occurs. So we're contracted with 15 managed care organizations on Long Island, 4 on behalf of our network of healthcare providers and CBOs. CBOs are, like we mentioned, there's large CBOs that are providing complex behavioral health and substance use disorder services, small ones that are doing very mom and pop things. I have 5 health systems, large health systems, 2 FQHCs. We're talking about a lot of different, and then also small mom and pop primary care service providers. So there could be a small mom and pop primary care provider, a healthcare provider, that reminds me more of one of my small CBOs, and one of my really large CBOs that reminds me more of my FQHC. So we really have to just say and understand who these providers are. We need to have relationships with them. We need to identify their greatest strengths and let that rise to the top. Share that information across the network so that they're sharing information with each other and recognizing each of their strengths and capacity. And really that is through convening. And, it would be great if we could kind of absorb information somehow, but it's just not the way it works. We have to convene. We convene monthly. We could, as an entire network, every month since 2017, we have convened. Yeah, it's a little hot, right? And then we also have a governing body that convenes every month as well in order to make sure that overall, how are we doing as a network? Are we doing well or are we not doing well? And then we have a lot of other kind of meetings where we do onboarding, contracting, going through all of that process, doing all of the onboarding for our technology, all of the training, a lot of workflow development, because it's not just the technology. The technology has to match the workflows, going through all of that. Talking about payments, invoicing, because we're paying our CBOs and our healthcare providers. I'm paying my large healthcare systems to provide services on our network as well as our small CBOs. So, talking about all of that and allowing for each one to teach us too. What do we have to learn from each of them so that we make sure that we're creating a full system that lets all boats rise, right? When one boat rises, we all rise. And so how do we do that together as a network?
A big takeaway there is when you're building your strategy and bringing CBOs together in a formal network or not, set up a community of the community-based organizations to be talking together on a regular basis. That seems to be critical, like the team meeting, if you will. I'm going to bring in Laurie, Stradley, and Evan now at Jones. So Laurie asks, what are the first, when you're thinking about this blueprint now, I want, and you're thinking about sort of making social care delivery more efficient, what are the building blocks? And then, Evan,
Okay.
you come in and right after Evan and build on it and see what signals you're looking for to make sure CBO is ready to go and to scale and all that. So we'll do in the end here.
Yeah, great. I'll start, Evan. I'll hand it over to you. I want to pick up something that Laurie, a thread that she had, which is actually what I want to say. It's this through thread. There are so many organizations operating at so many levels, just as Laurie described, that there are very few of us that are in relationship with all of these layers. And so we're predominantly serving a rural space, which means that we have other barriers in addition to, just the sheer number of people who are making decisions about healthcare practice, policy, and innovation. We also have transportation and distance, access to high quality internet. So even the idea of meeting on Zoom every month sometimes can be disrupted as we come together. So, getting it started is really about being prepared as the agency, at Impact Health, to talk a lot of different languages, to listen and bring all of these pieces to be able to translate them. And really, it's about identifying the people who are excelling in their areas. And I mentioned that before. We are contracted with about 60 community-based organizations. It's a combination of nonprofits and government agencies for the most part in our region. And we have to be able to figure out what they do best, make sure that they're connected with other folks who do great work in other areas, and build relationship between them. So we're not a series of transactional relationships with these 60 hubs. We are, just like Laurie said, bringing them together because they have to trust one another as much as they trust us to work with payer groups. We have 7 MCOs in Western North Carolina. 5 of them are a standard plan, and North Carolina also has something called a tailored plan, which is meant to support folks who have more complex behavioral health needs, substance use disorder history, intellectual developmental disability. And so we have sort of 2 types of payers that we're working with. And so really understanding the payers' needs, the individuals they're serving, the community organization needs, and the connection points that they all require. And again, really highlighting the expertise. One of the issues we found early on with some of our community-based nonprofits is that sometimes they will feel compelled, because they're all doing mission work, to add on different services that they may not be their expertise, but they see a gap there. And if we can help agencies see each other and see each other's excellence, then there is less mission drift, less scarcity of resources, and more efficiency in delivery. And one of those examples is this incredible group we work with. Working Wheels is their name. They've been in operation for a couple of decades here in Western North Carolina. And to highlight a rural health need is transportation. Transportation is a huge barrier to access of any type of care in rural spaces. One of our jokes when someone asks you for directions is, you can't get there from here. It's just very spread out. We don't have a lot of highways, and folks have to be able to navigate these spaces. They don't have access to any type of public transportation, and there is some infrastructure for government-funded transportation. So Working Wheels repairs vehicles, and they make sure that people have access to reliable, safe transportation in the form of a car, typically. And when we partnered with them, they began to serve. They were already serving most of Western North Carolina, and they expanded. And their model is to develop relationships with mechanics and other car repair shops to do this work. We don't need all of these 60 nonprofits talking to their local mechanic to help out. It disrupts the system, creates a lot of extra administrative burden, and potentially alienates our business partners in the community. And so being able to highlight those agencies and help the other agencies see how excellent they are as we build a network that is responsive to community needs and partnered in ways that are more effective and efficient than they could be if they were out there on their own. And so when we talk about the building blocks, again, it's going to be that bright spot model of who's already excellent and how do we keep them going. And in some cases, that may mean cross training. So I answered one of the questions that came in through the Q&A about how are we streamlining these other services that operate outside, like WIC and food, SNAP, that sort of thing. And the reality is that some of our agencies are already expert at that. They are counseling and supporting people to do it. Do we need all 60 agencies to be excellent at that? We absolutely don't. But if they trust that agencies like Manna Food Bank have experts on staff that are going to help people streamline their resources and meet the whole household's food needs, which will ultimately have better healthcare outcomes for the members. That's what we need to do, either to redirect there or provide some cross training. So I'll stop there. And Evan, if you want to pick up where I left off.
Yeah. Hey, Evan, before you do, I just want to, because I know we're a little bit behind on time, I just want to give everyone just a quick, I promised everyone just to tell you a little bit more about you guys. And so there'll be more context as you build your blueprint here. Vircho is a operating system to help you build social care networks. It helps health plans, Medicaid programs, and CBOs just strengthen their compliance, reduce all these inefficiencies we've been talking about, and optimize capacity so that networks could scale, improve member outcomes, reach more members, just do a better job taking care of the community. And the organization, like, you're able to gain visibility into your CBO, capacity performance, you're able to view the financial health of your CBOs, you're able to reduce blind spots and free staff up from this time-consuming manual tasks and all the sort of what I'll call administrative minutia that comes from working with a Medicaid in a Medicaid environment. So when you're thinking about automation, compliance, reporting, streamlining payments, all that stuff, Vircho provides all of that and all those tools to networks to just allow everything to run more efficiently. So they're really filling a big unmet need as we're all trying to get more scale and innovate and keep our costs down, especially in the post-OBB world. So check them out, vircho.com. And if you want to schedule a meeting with Evan, not even just to talk about the platform, but more in just a more of a consultative way to hear what's going on and what different organizations across the country are trying to do here in sort of the CBO world, just to get I'll call it a networking call. We'll set one up for you. I'll make an introduction personally with Evan, and we'll put up a poll there if you want to meet with him. So Evan, while people are just setting up, hey, I want to meet with you, why don't you talk to us a little bit what you could add to the blueprint as far as the two Rorys set us up here. We're building up this like blueprint for everyone.
Yeah, thanks for that, Eric. Spot on. So I think it's really interesting and just building on what Laurie had just said. So really trying to find the bright spots in CBOs for networks and in many cases, bringing those, top performing CBOs into network before you've actually worked with them. How can you find signal in data? And I think if you are an MCO, you're super familiar with building out a healthcare provider network. And, Dr. Khaldun mentioned HEDIS measures, right? There are a whole body of work for HEDIS measures, AHRQ measures, provider management tools that exist. And that type of infrastructure is, I think, sadly lacking in the social care space. And I think that that's something we all need to change so that we can start quantifying some of these things. CBO networks are oftentimes built on local relationships. And while those are incredibly important, I think a lot of sort of front-facing networks and CBOs are starting to realize they need to bring some data into that conversation when they are selecting and building out their CBO network. And I think it's worth saying as well that we need to be able to use data ethically and not allow bias that data might bring in to impact those decisions. So we need to make sure we guard against that. But when I think about the signals that we can discern about what makes a high performing or a healthy CBO that then would allow it to scale up in service delivery, I sort of always come back to the Donabedian paradigm for health services of structure, process, and outcomes. How can we apply that to social care providers? And so when I think of structure, what can we know about a CBO independent of the services that they are delivering that might signal quality before we bring them into a network and ask them to, by a multiple of 10, increase the services that they deliver. So we service a lot of measures in what we call CBO health. So things like organizational size in terms of revenue and staffing. Are they already financially sustainable before we bring them into the network? Are they reliant on a specific single grant? So as we've seen over the last 6 months, if they're reliant on federal grants, that might be pretty risky in this environment. All of those types of measures we can bring in from their 990 tax filings that all nonprofits have to make. And those factors are going to help us as network administrators or MCOs identifying a risk profile for that CBO if we're going to ask them to take on a lot more burden. When we think about process, what would show to both of the Laurie's points, how do we know that a CBO is going to deliver effective and efficient services, right? So once we start working with them, and we're working with the closed loop referral platform, like Laurie Andrade mentioned, we can measure things like time from the referral to the acceptance of the referral by the CBO, time from the acceptance of the referral to the actual delivery of service. We don't want our members or our community members waiting weeks and months to receive the food box that they've been referred to. That's not acceptable. The member is going to have a really bad experience. Similarly, we do track revenue cycle measures, so like invoice timeliness, documentation quality, denial or rejection rates of claims. So all of those types of things are going to indicate to us what is their operational reliability. And then I think, always most important is outcomes. Outcomes are pretty important and pretty difficult in the social care space often. So many organizations, I know Laurie Stradley does this, they're going to do post-service member feedback, right? Did you enjoy your service? We can, to Laurie Andrade's point, we can break down that silo and join that in with other data that we're collecting about the services. What is leading to a positive or negative experience? But then we can also look at quantitative measures. So one thing we've looked at is reauthorization rates. So when the member is eligible for a reauthorization of that same service, did they work with their CHWs and their care management team to actually get a reauthorization for the same CBO? That's going to indicate that the member or the individual said, hey, I want to keep receiving this service. We were pretty surprised when we looked at that. We found a really wide disparity between CBOs in the same network, in the same community, delivering the same services, having really different reauthorization rates. And, if you're in the private sector, right, you would think of a renewal of a service. That's a really important measure of how the quality of your service. So I think those are some of the things we think about. I think, just to put a point on it, why does this matter? I think that programs are going to scale up in this space. We all want to have more people using these services and being part of these networks. Regulatory guidance is going to constantly evolve. You have to create a network of resilient and high quality CBOs to meet those changing demands.
Right. It strikes me what we'll do, folks, if you give us a couple of minutes to fill out that survey, we're going to take all this great information, especially the last 15, 20 minutes, and create an actual, we'll call it Bright Spots draft, of the blueprint of how, you can, raise your game in the CBO community care space here. When we're thinking blueprints, we'll just try to write one out for you guys using all the information that we're capturing right now. Want to get a couple more questions in before we completely run out of time here. Want to come back to Dr. Khaldun. Joneigh, when you're thinking about innovating and scaling, what are some opportunities that everyone watching and listening, what are some opportunities for them to make an impact in 2026 with Medicaid members specifically?
Yeah, thank you. I think I want to build upon this kind of concept of a blueprint, and also one of my pet peeves working in local state government is you often have government agencies, CBOs, they're like tripping over the same community members or plan members or patients, sometimes providing the same services. No one's really kind of connecting the dots on who's providing services to who, how are those outcomes kind of panning out. And there's often, not explicitly stated, but there's often even competition, right? Like, oh, well, I'm going to be the savior of whatever thing for whatever health outcome. And so you often have CBOs and agencies like tripping over each other. So to the point about the blueprint, every health department who is accredited, and many who are not, have to do a community health needs assessment. Your local hospitals, if they want to maintain their nonprofit status, they're also doing a community health assessment to keep their tax exempt status. So really, I think an opportunity in these challenging regulatory times where no one has time to be wasting or tripping over each other, there's a real opportunity for, I think, plans, CBOs to be at these tables to align on the timing of these assessments. How about we just make them one assessment? Bring the Medicaid plans to the table. Look at the same kind of data sets. Because what's happening, not only are they doing these assessments, they're also designing implementation plans and the actual strategies in those communities communities, because some of this is happening already. But I think now is the time to really accelerate that collaborative work and that blueprint, because unfortunately, again, we don't have time to be wasting resources. We don't need like 20 different blueprints in one community, okay? And then I'll just add to that, an earlier point I think Laurie Andrade brought up is the value of community health workers. I think really scaling community health workers, but also importantly, and I've seen this, people don't need multiple community health workers, one from your plan, one from your health department, one from the hospital because you were just discharged. Like those community health worker networks even need to be better aligned. I just think there's a lot of waste, dare I say. There's a lot of waste and tripping. And I think this is the time to really lean in on, let's not compete with each other, but let's really align around a singular blueprint for a community, not 20.
Good stuff. All right. I'm looking at the time. I'm sort of in no man's land here. I don't want to go long, but I do want to see if we could squeeze out some more insights and bright spots from everyone. So I'm going to go do a quick little round the horn rapid fire here. And I'll start with you, Evan. I think the question is going to be if folks could do one thing or think about one thing as they think about their social care strategy in moving throughout the end of this year and certainly thinking about next year, what would it be? What would you recommend doing? And we'll start with Evan, and then we'll go with Laurie A, and then Laurie S.
Yeah, so I guess from my perspective, a little bit different than both the Lauries who are on the ground working with the CBOs, but from a network management standpoint, I think it is identifying and defining the measures that you think are going to matter for delivering high quality services to your members and your community members. And then, because I think the first thing we have to do is define those before we can start measuring them and demonstrating impact. And I think we often jump to the second or third hoop. And in this space, I think there's a lot of great work that needs to be done to just come up with those measures. And so I'll set Laurie Stradley up, but the state of North Carolina had a great JAMA paper and report that showed that, their program is saving over $1,000 per member per year to their Medicaid plans by offering social care. That's the type of thing that we need to have across all plans in all states, but you have to start out with the goal of what you're going to measure before you start collecting the data and being able to actually prove it.
Awesome. Laurie A.
Yeah, trust. I often say this network, stands up and falls at the speed of trust. And really what we're talking about, having one blueprint, being able to share data, everything needs to be transparently shared, right? In order to be able for everyone to be driven by one blueprint or be able to use that collective data in order to be able to make decisions and coordinate, there needs to be trust. There needs to be trust between the different types of providers, the CBOs, and oftentimes the CHW does help with that trust with the actual members. That we need to really be focused on the trust with them as well. But that's what I often focus on, is making sure that we're being very, very communicating very regularly, bringing folks to the table, giving them their space to show their strengths, and to be able to build a trust between the different siloed systems to make sure that we have one system of care for Long Island and Long Islanders, so that we really put them at the center of care and their needs come first.
Good stuff, Laurie S. Take us home.
I won't argue with them. I'll say those two were great. So that gives me the space to have a third piece, which is when you know what the measures are and you have deep and longstanding trust, then you have to move to standardizing this approach to the best ability possible. And I mean that from the big things about data and relationship to the small details, like what does the contract look like? And if we can standardize that approach to the best of our ability, then we prevent those community-based organizations from over-medicalizing. And that is that piece where we keep people doing what they're great at. And that's why with the partnerships that Laurie is talking about, the trusting relationships and that backbone of data aggregation and data sharing that Evan and his team have brought to us, we can move into those nitty-gritty details and make it function as smoothly as possible across the region.
Good stuff. Thank you. Great job to all of you. Thanks so much for all the time you took to prepare with me. To everyone listening and watching, a sincere thank you for tuning in. We never take the time you spend with us for granted. So we hope that you gain something from today. as I said at the beginning, in Camden, New Jersey, it was one coalition showed us that even small changes could spark a much bigger movement and impact in the community. And that's what today's been about, finding these bright spots, figuring out what could be scaled. We're going to send out a blueprint to anyone that takes out that survey so you have more to work with and inspire you and help you lead kind of your own moonshot in Medicaid, because that's what we need in our industry right now. So that is the only way, in my opinion, that we truly fix healthcare in our lifetime. So let's do it. Find what's working from these great experts in front of you and clone it. Thanks again for joining us. This is your Bright Spots in Healthcare podcast. Take care, everyone.